In this video, we present a case of radiofrequency ablation as a treatment for recurrence of papillary thyroid carcinoma metastatic to a left level 4 cervical lymph node. The patient is a 38-year-old female who presented to her general endocrinologist with a 1.2 centimeter intrathyroidal papillary thyroid carcinoma. She underwent a total thyroidectomy followed by radioactive iodine ablation with 154 millicuries of I-131 by her treating physicians. Post-RAI therapy scanning showed uptake on the left. The patient was subsequently referred to a radiology center and was found to have a suspicious lymph node at level 4 on the left that measured 1.8 by 0.7 by 0.8 centimeters. Malignancy was confirmed by FNA cytology at the radiology center. Serum thyroglobulin at that time was 1.5 nanograms per deciliter. The patient was offered surgery by her general endocrinologist and surgeon, but she refused and was subsequently referred to our center for radiofrequency ablation. The patient was placed in the supine position with hyperextended neck, and the target node and vital cervical structures were visualized with ultrasonography in real time. Here we can see the vital structures. Note the proximity of the target node to the jugular vein as well as the location of the vagus nerve. The hydrodissection procedure was carried out around the lymph node, isolating it from the jugular vein and other vital structures. 2% lidocaine was used for local analgesia. Subsequently, 5% cold D5W, 0 to 4 degrees centigrade, was used to hydrodissect the carotid artery, jugular vein, and the vagus nerve away from the malignant node. The electrode antenna with a 5 mm active tip was advanced into the node under ultrasound guidance from a lateral to medial direction. Ablation was performed using 30 watts of power. A fixed ablation technique was used given the small size of the node and the inability to safely use a moving shot technique. Ablation can be seen by the hyperechoic changes within the target node. The electrode was repositioned and a second ablation was performed to ensure that the node was completely ablated. Again, the hyperechoic signaling on ultrasound can be seen during the ablation procedure. The patient's vital signs and voice were reassessed following the procedure. No hoarseness or other abnormality was noted. The patient used ibuprofen for discomfort and made an unremarkable recovery. Follow-up imaging at 6 months revealed that the metastatic lymph node was no longer visible on ultrasound imaging. Thyroglobulin levels at 6-month follow-up were undetectable at less than 0.1 nanograms per deciliter.